Welcome, everyone, and thank you for standing by. At this time, all participants will be on listen only until the question and answer session of today's conference, at which time you may press star 1 to ask a question. Today's conference is being recorded. If you have any objections, please disconnect at this time. I'd now like to turn the meeting over to your host, Ms. Margaret Farrell. Ma'am, you may begin.
Great, thank you. Good afternoon, everyone. I'm Margaret Farrell, and on behalf of the National Cancer Institute and our speakers today, I'd like to welcome everyone to our September NCI Research to Reality Cyber Seminar. NCI launched the Research to Reality Community Practice 5 years ago with the aim of bringing together researchers and practitioners in an ongoing discussion around the promise and, without a doubt, the perils of moving evidence-based cancer control programs and policies into practice. Not exactly like this cartoon suggests, but something along those lines. And central to this work is actively engaging key stakeholders to take up evidence-based practice. Engaged and energized stakeholders not only improve practice, but provide researchers and practitioners a greater appreciation of the context in which a research-tested program is implemented. And we really have an all-star cast today to help us kind of grapple with this issue. The Center for Disease Control and Prevention's Dr. Brooke, Steele, and Angela Moore will present on the recently published article about the use and attitudes about evidence-based practices by coalition partners. Brooke and Angela further discuss some implications from this research and some ideas around working with diverse populations and working with effective coalitions as well. And as a complement to that presentation, our R2R Coalition Corner, Karin, Hohman, Leslie Given of Strategic Health Concepts will unveil their long-anticipated toolkit, The 9 Habits of Successful Comprehensive Cancer Control Coalitions. And this resource outlines a set of evidence-based, comprehensive, and interconnected characteristics of coalitions that have been successful in maintaining an active coalition. And we're most fortunate that they'll be joined by John Aldino, who's the Senior Director of State Health Systems for the East Central Division of the American Cancer Society. And John will share the story of the Ohio Partners for Cancer Control. Complete biographies of all of our speakers can be found on R2R. That's researchtoreality.cancer.gov. We specifically and warmly welcome those of you who are joining us for the first time. Following all of these presentations, we'll host a robust and interactive discussion with you about your experiences. And we welcome you to engage with the discussion today on the call and also online on R2R. We're really excited that you're joining us, and I'm particularly excited to see so many coalition members who are already online, and we hope to hear from you today as well. So, Brooke, with all of our housekeeping done, I'm delighted to turn this over to you and our other speakers. Thank you.
Thank you, Margaret. Good afternoon, everyone. As Margaret indicated, I'm going to present findings from a study of use of evidence-based practices among National Comprehensive Cancer Control Program, or NCCCP, grantees, and some of their partners. I'll present a brief background of NCCCP, discuss the purposes of the study and the study methods, present key results, and also discuss how the findings can be used by programs and coalitions. So for those of you who don't know, comprehensive cancer control is defined as a process through which communities and partner organizations pool resources to reduce the burden of cancer. NCCCP was established in 1998 to provide funding and technical support to comprehensive cancer control programs for the development and implementation of cancer control plans. This map shows the 65 programs that are currently supported. They include all 50 states, the District of Columbia, 7 tribes and tribal organizations, 7 territories, and U.S.-affiliated Pacific Island jurisdictions. Grantees are encouraged to use evidence-based practices to develop cancer control and annual action plans, as well as to report progress. The purposes of the study were to assess how NCCCP program directors and selected partners work together to identify and use evidence-based practices, herein referred to as EBPs, to identify what resources they use to locate EBPs, to assess perceived benefits and challenges to using EBPs, and to identify what technical assistance needs they have related to EBP use. EBPs in this study were defined as public health practices that have been tested and evaluated and shown to be effective. The extensive use of EBPs among grantees was a concern because documentation of these practices and some action plans has been inconsistent. Often the source of the EBP was not identified, or the source did not match the activity that was described in the action plan. In 2012, CDC worked with a contractor to conduct surveys of program directors and up to 4 referred partners per program. Partners with knowledge of and experience in identifying and implementing EBPs were preferred. Program directors completed online questionnaires and were interviewed by telephone. After excluding programs that piloted the survey, the program director participation rate was 92%. Partners completed online questionnaires only, but these questionnaires included 2 open-ended questions about the benefits of and challenges to using EBPs. The participation rate among them was 52%. Again, this was after excluding those who participated in the pilot. Moving on to key results. This table shows selected characteristics of the respondents. As expected, the distributions by jurisdiction type were similar. 4 partners and program directors have been working with the comprehensive cancer control programs in their jurisdictions for 4 or more years. Educational attainment was similar for both groups. Most partners represented organizations, including voluntary health organizations, healthcare systems, and local health departments. Program directors were asked about the extent to which EBPs are used to develop cancer control plans and to develop objectives in annual action plans. Overall, they reported fairly high use in both cancer control and action plans, with nearly 75% reporting use to a moderate or great extent. During the telephone interviews, program directors were asked to describe how they work with partners to use EBPs. Most said they consult with partners and rely on their expertise. For example, they'll solicit input about which EBPs to focus their activities on. Roughly 40% said they often work with a subset of coalition members to capitalize on their expertise, including those with implementation skills. Nearly 30% of program directors indicated that they provide resources and other support to help their partners implement their own cancer control programs. Only about 20% said they work with partners to identify or implement EBPs. When partners were asked how they work with comprehensive cancer control programs to use EBPs, most said they are involved in 4 core activities of EBP use: identifying, adapting, implementing, and evaluating. This seems inconsistent with the perceptions of program directors. However, directors were asked to refer coalition members who had knowledge of EBPs or experience implementing them. Not surprisingly, more than 90% of the partners said they are involved in implementation. From a list of 14 theory-based characteristics related to the selection of EBPs for cancer control, respondents were asked to select which ones are not at all important, somewhat important, moderately important, or very important when choosing EBPs. Table 2 shows the characteristics that respondents identified as very important. There were a number of similarities, including cost effectiveness, available for free or low cost, easy to evaluate, other organizations are using the EBP, and people in the community requested the EBP. Among the notable differences was consistency with our organization's mission. This was the most frequently reported characteristic among partners, but cost effectiveness was reported most frequently by program directors. Program directors and their partners identified similar benefits to using EBP, including they're proven to work, their efficient use of resources, they lend credibility to their programs, they're measurable, they benefit the community, and they come with technical assistance. Both groups also identified many of the same challenges, including limited resources, lack of appropriate EBPs for specific populations and communities, limited skills adapting EBPs, lack of guidance on implementing EBPs without losing fidelity, the need to obtain community buy-in, and difficulty evaluating and measuring outcomes for EBPs that were tested in research settings. First two barriers were mentioned by nearly all respondents. Table 3 shows the training and technical assistance needs reported by program directors. They were asked to identify which of these training areas would help their programs identify, adapt, and implement EBPs. Consistent with the challenges of using EBPs that they identified during interviews, adapting EBPs for cultural appropriateness and maintaining fidelity when implementing EBPs were reported by most. And not surprisingly, how to find additional resources remains a concern. Many also still need help implementing EBPs. This may be related to difficulties adapting and implementing them with fidelity. How could your program or coalition use the study findings? You could assess your programs or coalition's use of evidence-based practices. For example, ask, are EBPs used consistently to develop cancer control plans and action plans? Have you used the Library of Indicated Database System, or LIDS, to help develop program objectives? Are you clearly documenting use of EBPs in your action plan? Are there other resources that you could use to locate EBPs besides Cancer Control Planet and the Community Guide website, Awardees, for example? You could also start a dialogue with your partners about contributing to the evidence base. Do you have results from evaluation of an intervention or promising practice that could be published? You would also need to ask if your program staff have the skills that are needed to publish. So these are just a few things that your programs could do to improve its capacity, or their capacities, to use evidence-based practices. Next, Angela will discuss approaches to building overall program capacity.
Thanks, Brooke. So I'm going to now dive into my presentation, which is to talk about ways in which you can maximize your comprehensive cancer control program and ensure a capacity as it relates to ensuring that that program is utilizing evidence-based practices. Here are the objectives here. I will rely on some research that has been done around capacity and talk through what those critical elements are. I'll talk a little bit more about the comprehensive cancer control program design and how it fits into the idea of having an evidence-based program. And I'll end with ways in which you can maximize the capacity to build an evidence-based program. So let's define capacity here. So there are numerous definitions in regards to program capacity, organizational capacity, or program capacity. I actually would like to use Sarah Shell's and her colleagues' definition of sustainability capacity, which is the existence of infrastructure or processes that really allow the program to leverage all resources available to effectively implement and maintain evidence-based practices. So here are the critical elements. This is just a list that I've developed based on some seminal articles by our CDC Director, Tom Frieden, Sarah Shell, and a colleague in the Office of Smoking and Health, Renee Levenhouse, who developed a component model for infrastructure. So as you see here, at the top of the list are the whole idea of developing promising practices, the use of evidence-based interventions that Brooke has touched upon in her presentation, program monitoring and evaluation, the building and sustaining of partnerships with which our colleagues John and Leslie and Karin will go through, the engagement of decision makers, the ideal of conducting strategic planning, using effective communication to engage stakeholders, and the whole idea of managing and diversifying your resources. So the National Comprehensive Cancer Control Program has actually undergone a lot of growth in the years that we've been developing and implementing this program, but a few things remain the same. So here you do see the ideal of building your partnerships, assessing and enhancing your current infrastructure, mobilizing support, and again, utilizing research and data to inform program action. So these things actually move us towards cancer prevention and control changes at the individual program and policy level, and to have hopefully impact as it relates to morbidity, mortality, decreased disparities, and enhanced quality of life. So what's different now? Well, not a lot, but there are a few differences in our new program logic model. Evaluation is now seen as something that occurs throughout the lifehood of the program, and it's a high priority. And what you'll also see in this program logic model is the whole idea about managing your program and funding effectively. You'll also see front and center that a grantee activity is to assemble, support, and collaborate your CCC partnerships, as well as create and implement plans that use evidence-based practices. But, capacity building is a group effort. And so CDC does not do this alone, and the programs and coalitions do not go along in this effort, too. In order to do sustainability capacity well, we have to rely on our national partners, CDC's technical assistance to the National Comprehensive Cancer Control Program, as well as the work that you all do within the programs and coalitions. So again, let's walk through quickly some tips of how you can maximize your comprehensive cancer control efforts utilizing these efforts here. What I'd like to reiterate is that these elements seem to be across the board in the research that I outlined prior, and that Brooke has done a really good job of talking about evidence-based practices, and I'm going to leave it up to my colleagues Leslie, Karin, and John to talk about how to build and sustain partnerships. So as it relates to promising practices, it's really important to think about building the evidence base, and also to effectively use data to design your public health program. And so these are just some examples of shoring up your communication techniques using those things that are different, such as social media, which is something that a lot of us are beginning to do, utilizing different techniques such as photo voice or digital storytelling to either assess a program or an intervention or to disseminate evaluation results. And again, utilizing different surveillance systems to inform evidence-based practice. Steele and Frieden also identified that effective performance management, monitoring, and evaluation is essential to capacity building. So again, for comprehensive cancer control programs and coalitions, these are some ways that you can get involved and ensure that you're shoring up your program and ensuring that it's an evidence-based built program. Engaging programs as well is very important, and also engaging your decision makers is an important part of this. And again, we rely on our Comprehensive Cancer Control Coalition members to do things such as provide resources, explain the burden of cancer in community, identifying and educating your program champions, and developing and implementing a media strategy that ensures that your priority policy systems and environmental change strategies are implemented well. This other element, I would say, is something that comprehensive cancer control programs and coalitions do quite well. So whether your CCC program is a living document or you work with your coalition to update it every 5 to 10 years, it's really important to make sure that you start early, that you have the right people at the table, and that you utilize your data and evaluation results to add to and revise your plan. Another important element related to sustaining capacity, ensuring that your CCC program is evidence-based, the whole idea of being able to effectively communicate and disseminate your program outcomes and activities. And this can be done in a variety of ways. Success stories is something very new that folks are starting to do, that I encourage individuals to do, as well as those peer-reviewed journals that disseminate lessons learned as you begin to implement both promising practices as well as evidence-based ones. Lastly, the last critical element is something that I think all of us realize is conceptually something that we need to look at, and that's the management and diversification of your resources. At a minimum, to try to identify what it takes to implement your comprehensive cancer control program. Things to help with that is determine which activities currently align with your mission and goals, and determine those essential services that are needed to continue regardless of whether or not federal funding is available. Seeking out different avenues as well as foundation funds or fundraising through coalitions, if that is something that your coalition is equipped to do. So the takeaway here is that as this program and the coalitions continue to grow and evolve, capacity to ensure successful implementation of evidence-based cancer prevention and control activities must be attained. And that there are many program capacity models that exist, but the critical factors that I talked to you about, these are things that we've seen across several different researchers' work. And if we hone in on those things, we can ensure that the evidence-based program that we know as comprehensive cancer control will be successful. So with that, I'm going to turn it over to my colleagues Leslie and Karin and John, and they will talk to you about habits of successful coalition building. Thank you.
Thanks, Angela. Hi, everybody. This is Leslie Gibbon. Want to say thank you to Margaret and NCI for asking all of us to be a part of this webinar today. We want to talk to you about the 9 habits of successful coalitions. Hopefully this looks familiar to some of you, many of you. And we want to spend some time having John talk to you about what Ohio has been able to do with some of these successful characteristics of successful coalitions. So we have had these 9 habits around for quite some time, and many of you may recognize them as we go through them. Some of you may have been involved in some some workshops that were conducted a couple of years ago. Some of you have made and reviewed this guide and given us feedback, and we appreciate your help. So this guide has just recently been released by the Comprehensive Cancer Control National Partnership, and it's on the newly launched Comprehensive Cancer Control National Partnership website. So perhaps after the webinar, we can put up a link on Coalition Corner on the R2R site, and you can make sure that you can click on it and get to the habit guide. So just a little tiny bit of background. The habits are very much based on evaluation results. It was evaluation that was conducted by the American Cancer Society and CDC, and it really looked at how have coalitions been successful in their efforts to develop and implement cancer plans, and particularly focused on implementation of cancer plans. And so these habits grew out of those characteristics of effective coalitions. And the habits are very much interconnected. They're very comprehensive. They tend to be sort of, the way a coalition can operate that becomes a part of the coalition, the organization's values, and helps them to be successful, and therefore very much integrated into the work of the coalition. In the guide itself, it's a very practical guide. There are a series of questions, and for those of you who came to the workshop, you might remember these self-assessment questions that we used, and they're repeated in the guide with some adjustments. These questions allow the coalition to sort of look into how they're doing in each of these areas, in each of these 9 areas. And kind of do a self-assessment, and we'll talk about ways of using that assessment here in just a minute. The guide has in it for each of the habits a habit in action, which is just some basic information about how you can put the habit into action within your coalition. We've got a bulleted list of do this for your coalition, so you can get straight to the point and understand how you can put it into action. There are some spotlights of coalitions who have successfully used these habits, and you'll hopefully find yourselves in there. And so we wanted to just give some examples. There are many more than we could fit in this guide, but there's just some examples of how specifically comprehensive cancer control coalitions are using these habits every day to improve the way that they function. There are tools, matrices, questions, forms that you can use to take each habit and put it into practice for your coalition, make it a reality. And then within each of the habits, we have a section we call Making It a Habit. So it's kind of a place for you to write down your ideas about the actions you might take going forward to put this habit into action for yourself, for your coalition. So here's just an example of one of those assessments that we talked about. It's a very simple. You can use it in a lot of different ways with your leadership, with your full coalition, with your work groups, your implementation teams, your task forces. But we ask you, how do you rate your coalition on a series of statements? And based on that rating, it leads you into understanding how well you're doing in this area, how you might be able to improve. And so the guide includes an assessment for each of the 9 habits. And then at the end, we have them all put together in one place, so you can actually assess your coalition on all of the 9 habits. So these are the 9 habits. These are all things that are part of daily life. They're things that help make all relationships a little bit better. They're things that, again, can be integrated into the daily life of a comprehensive cancer control coalition. They're not rocket science, but there are things that we often don't think about, that we don't pay attention to. But if we did and just spent some time on it as a coalition, as a leadership group for a coalition, as a work group lead, as a member of a coalition that we might be able to make our work more effective. So we are going to kind of do a quick rundown of the 9, and then we're going to just focus in on a few in the essence of time, and we want to make sure we give John time to talk about how these have been used in Ohio. So empowering leadership is the first habit. It's exactly what it seems like, what you want in your coalition are leaders who empower others, individuals and organizations to get the work done. These are leaders who say, this is how we can do this together, not this is how I want you to do it. Their one habit is shared decision making, and again, not one organization makes all the decisions for the coalition, but it's a shared decision making process, and decision making rules are clear and people understand how they can be involved. The third habit is called value-added collaboration. We're going to spend some time talking about this, but it's essentially focusing on things that wouldn't happen otherwise as a coalition. The fourth habit is about dedicated staff and how important this is. It really, truly is something that makes a coalition successful. The takeaway here is that it's not always about staff dedicated from the Department of Health in the state, tribe, or territory. Sometimes it's staff that are dedicated to comprehensive cancer control plan implementation and sort of assistance to the coalition from other organizations like the American Cancer Society, for example, or a university. Diversified funding, and you'll see there are connections with what Angela and Brooke talked about here. So diversified funding is important. It helps make coalitions successful. So we want to see that not all the funding, and we know it's not enough, but not all the funding comes from the CDC to the health department. There are other sources of funding, either real dollars or in-kind funding from different organizations, so that if one pot of money or one type of resource goes away, the coalition itself or the effort doesn't go away. But we have different sources of resources. Effective communication is very much a part of successful comprehensive cancer control coalitions. Communication two-way, out to coalition members, from coalition members to the leadership. It's critical to the functioning of a successful coalition. Probably one of the major things that when Karin and I are working with coalitions, we work with them around clarifying roles and responsibilities and ensuring that accountability is set up within the coalition. This is something that, without recognizing it, sometimes can begin to trip up a coalition. If the role of the leadership group isn't clear, if the role of the members of the coalition isn't clear, if the role of the coalition itself as a whole isn't clear, and if accountability measures aren't set out, sometimes this trips us up. The other thing that's important is a flexible structure, and we'll talk a bit more about this in just a second. And the last thing is priority work plans, which is, we'll talk more about this one as well. It's not just about work plans, actually. The functional word here is priority. And what we see in successful coalitions is that they actually set priorities for themselves, pulling from the 5-year or sometimes longer cancer plan and saying we're going to work on these things over the next couple of years and really see if we can move this effort forward in this area. So pulling those things out of the cancer plan is really important as a way of focusing. So again, we're going to just hit on a few of these and then let John talk. So habit number 3, value-added collaboration. It's probably one of the more critical questions that you can ask yourself. So the ask is, what in the comprehensive cancer control plan would not happen if the coalition didn't work on it? Very simple. So if you find yourself kind of sitting around and talking to each other in your coalition meetings about everything each individual organization is doing versus what you're working on collectively and how that's going, you may not be focused on value-added things out of your cancer plan. So you want to make sure that you are focused on the things that wouldn't happen if the coalition didn't work on it. We know that individual organizations who are members of coalitions, whether it's the Cancer Society or the university or the health department, they're going to work on what they need to work on. Sometimes those things are in the plan. but what is it that we can work on together that wouldn't happen if we didn't do it together? So that's habit number 3, value-add collaboration. Again, this is habit number 7, very important, clear roles and accountability. I don't know how you would answer this sign. Piano player wanted, must have knowledge of opening clams. So sometimes roles are not clear, and sometimes that keeps people from being engaged in the active functioning of the coalition, the day-to-day work of the coalition. So one way to ensure that roles are clear is to put them in writing. Say, how many calls are you expected to be a part of if you're on the leadership group? How many meetings? What's the length of your commitment? You have to remind members about their role. One thing that a lot of coalitions who are successful in this area do is they ask coalition members to recommit every year, every so often, to being a member of the coalition and to recommit to the vision and to the mission of the Comprehensive Cancer Control Coalition. Another thing is to encourage people to take on different roles. We don't want people to be static. And big thing is to be very clear, and sometimes we just glaze over this, but to be clear of the coalition's role as a whole. You'd be surprised at how many times we start working with the coalition, we ask, what is it that you've come together to do? And if there are a lot of different opinions and not a lot of coalescing around an idea, then we know we need to work on that. So a couple of things that was about clear roles, but also part of this habit is about accountability. And it's not always easy to do, but there are some simple things that you can do, and especially in terms of setting expectations, putting on a little bit of peer pressure to sort of force people or have people make sure that they have a critical role in an effort, that they know they need to report out. And then, of course, another way to increase accountability is to really thank and to congratulate members. And many of you, as Comprehensive Cancer Control Program Directors and Coalition leaders, have some really nice programs that recognize your coalition members for their contributions, and that's really important in pushing accountability. The habit number 8 is flexible structure. This is really important to getting active involvement in your coalition. So we often ask people to think about this question, does your forum follow your function? So is your coalition set up around the things, the priorities that you've identified that you want to accomplish together? Are you set up actually to work on that? If you haven't changed the committees for the last 10 years in your coalition, you might want to take a look at that and think about, are we really focused on very specific things, those things that are value added that we know we need to push together as a coalition. Encourage people to move around, and big thing is don't let bylaws get in your way or be a barrier to getting work done. So another habit is around priority work plans. This is the last habit, and there's 2 parts to this, as I mentioned before. One is actually about setting priorities, and the other is having these work plans to assure that you're on track with what you're doing. So setting priorities is extremely important. A plan is comprehensive, but you can't do everything at once. Many plans have 30, 40, 50 objectives, all beautifully set up. They're all measurable. They have baselines and targets, but you can't possibly do all of those 50 things immediately from day one of your plan being published. So you really need to think about, how can we set priorities? How can we focus on those things that are value added? Once you set those priorities, work on them for a couple of years, and then reassess and figure out if you need to keep working. Maybe you change the strategy underneath that objective, but you need to set specific priorities for a shorter period of time within your cancer plan time frame. And then, of course, having some kind of a written work plan is really important. It reinforces what's expected. It reinforces sort of keeping accountability at the front of mind, and also it's in writing, so it's there for all the members to see exactly what the work groups, the teams, whatever you call it, the committees, are working on and what the end goal is. So there are lots of different ways to take that guide and use it. You could address 1 or 2 habits during each coalition leadership meeting over the course of the year. You could have a retreat around all of the 9 habits and just go through that assessment and ask yourselves, how are we doing here? You could have work groups dedicate a portion of their meetings to one of the habits that seems most important to them, that they need to do the most work on. You could actually use the self-assessment tool with the full membership, and we've seen a few coalitions do that coming out of those workshops that we held, and that was very helpful, very powerful for the coalition as a whole. So with that, I want to turn it over to John and have him talk about how the Ohio Partners for Cancer Control have recently used some of these habits in their work. John?
Well, hello. Again, my name is John Alduino. I'm the Senior Director for State Health Systems for the East Central Division of the American Cancer Society, which covers both Ohio and Pennsylvania. More importantly to this group, I have the pleasure of being on the Ohio Partners for Cancer Control Executive Committee, and I'm also the co-chair of the Stakeholder Leadership Team, which is the Comprehensive Cancer Coalition in Pennsylvania. So in 2014, the Ohio Partners for Cancer Control was in its last year of its cancer plan, and we were lucky enough to receive some technical assistance through the Comprehensive Cancer Control National Partnership. The assistance was to help us create our new cancer plan and help us think through how we can improve the functioning of the executive committee as well as the coalition as a whole. We had a series of face-to-face meetings, some conference calls, and we also had some homework to do as well. And throughout this process, we were able to accomplish a number of things. The first was that we created some and updated our written roles and responsibilities. And I think, like our bylaws, at some point we did have these written down, but I'm guessing if you polled our coalition members, they wouldn't know what they were or where to find them. So this was a good opportunity to take a step back and create some or revise these written roles and responsibilities. The other thing we did was we evaluated the time and frequency of our meetings. And lastly, and I think most importantly, was from our new cancer plan, we chose some priorities to work on and then organized around those priorities. So indeed, as was mentioned, our form followed our function. In previous years, we had always been a mile wide and an inch deep. And thinking through this 9 habits process allowed us to focus on a few things. Our early detection committee is working on the National Colorectal Cancer Roundtable Initiative of reaching 80% screening rate for colorectal cancer by 2018. They have reorganized into 5 subgroups. We have a health plan group, a hospital group, a primary care group, an employer group, and a community group that are working on the 80 by 18 initiative. The prevention committee is working on several HPV initiatives, and our patient-centered services group is working on a survey to determine which types of patient programs and services are being delivered in Commission on Cancer hospitals. You know, I had a mentor that had a cartoon in his office, and the caption read, "Don't just do something, stand there." And, you know, this technical assistance in thinking through these 9 habits in the way we did allowed us to take a deep breath, review what we were doing, and try to make it better as we move forward into our new cancer plan. And the bottom line on all this is that a year ago, it would not have been so easy to tell you what the OPCC was doing and what their priorities were. So this process was very helpful, and we also completed a quality cancer plan in what I think was record time. I'm a fan of this work, and it worked out well for Ohio, and I think it will help us as we move forward with our plan and help to save lives from cancer in the state of Ohio. So thank you very much. I appreciate the time, and thank you for allowing me to share Ohio's story.
Great. Thank you also very much. I feel like, you know, it's baseball time in D.C., so I feel like, you know, we emptied out our bench, right, to to bring attention to this issue. So thanks, Brooke and Angela, Karin, Leslie, and John for those presentations. And I found myself writing down a couple of things that I wanted to follow up with in my own work as well. So this is a wonderful time to open up the phone lines and give everybody an opportunity to join the discussion. And to do so, I ask you can ask your question live by pressing *1 to be placed in queue, and the operator will get you situated for that. And or if you prefer, you can also submit your question using the Q&A feature at the top of your screen. You just have to type in your question and then hit ask. So while we're waiting for questions to come in, either with Q&A function or with *1, I was really struck by Karin and Leslie, your discussion about having value-added contributions to a coalition, and really kind of what, if we're all talking about our individual work, then we're not talking about the value add that coalition work brings together. And John, not to put you on the spot, but did you see any, or Angela, is there anything that you'd like to speak to, like around this issue of how you were able to move your coalition to having a more value-added focus to your work?
Yeah, this is John. I think that this whole working this way and this whole new process is somewhat new for us. But I think just being able to pick those priorities was very helpful, and then trying to pick what would then be the pieces that would be value added within those priorities.
This is Leslie. One thing I think that strikes me about this is the Comprehensive Cancer Control National Partnership is trying to not just talk the talk, but walk it. And so one of the things the National Partnership has done recently is ask ourselves that same question, what really do we need to focus on that wouldn't happen if we didn't? And that's how the National Partnership has arrived at 3 priority areas. One is increasing HPV vaccination rates through comprehensive cancer control coalitions. The other is getting behind the 80 by 2018 initiative and really engaging coalitions in that way. And then also we looked around and we didn't see a whole lot going on within at least the members of the organizations together around tobacco cessation for cancer survivors. And so in following the same process, and the National Comprehensive Cancer Control Coalition is a lot like a state, tribe, or territory coalition, the national partners came to a realization that these are the 3 value-added things that if we worked on together, we really felt like we could do something that wasn't being done now.
Great, thank you. We have a question. We have a couple of questions coming in. The first from, and maybe what we'll do is just sort of open the question and then take them one at a time. But a general question from Sarah Kirsch, who asks, regarding priority work plans, we're concerned that we may alienate some of our coalition members that do not actively work in the areas of focus included in the priority work plan. Are there types of priorities that you find cover the span of partners and their expertise to help avoid alienating some?
Hi, everybody. This is Karin. So let me take a stab at that. I think it's a valid concern. You want everybody to see themselves as contributing as an active member in the coalition, and you want all your members to do that. When we're talking about priorities, there's different ways that folks can, or different coalitions have done this. Sometimes what they do is they'll pick a priority along the lines of the full continuum. So something in prevention, something in early detection, something in diagnosis and treatment, survivorship, quality of life. And you'd be hard-pressed, I think, for anyone to say they do not see themselves in a priority along those lines. Let me give you an example. Often we hear somebody say, I am only concerned about breast cancer and really want to focus there. Well, if there's not a breast cancer priority, what happens to that person? Well, often, though, someone in a priority of the coalition, if it's not breast cancer, maybe you're talking about access to care, and access to care may be a priority. That person can actively get involved in that priority because it's going to benefit all cancer patients, not just breast cancer patients, not just colorectal cancer patients. So part of, I think, leadership of the coalition is enabling people to see how they can be involved and how they can bring their expertise and their experiences, even if their quote-unquote site-specific interest isn't demonstrated or isn't necessarily listed out as one of the priorities. Again, trying to figure out where their interests are and their expertise and their skills always in those priorities is part of that leadership group's, I think, responsibility, and part of the, if you have a work group, that lead really clearly delineating what skills, what expertise, and how other people can be involved.
And this is Angela. I would definitely agree with Karin's comments, and just to also reiterate that the National Comprehensive Cancer Control Program priorities are also set up that way. Our 6 priorities are in the areas of primary prevention of cancer, addressing the needs of cancer survivors, the promotion of early detection and screening, as well as 3 cross-cutting priorities that relate to ensuring equity or addressing cancer disparities, to assess the program and articulate outcomes through evaluation, as well as to implement policy systems and environmental change. So these priorities as well really dovetail nicely in with Karin's comments of, priorities in which individuals can definitely get involved in and have very meaningful work, not necessarily based on cancer type or on a particular risk factor, but looking at things a little bit more globally. And I think that our coalitions are uniquely positioned to do that kind of work.
Great, thank you. And John, I'll put you on the spot also. What do you find with your own work with different partners as interest waxes and wanes around different aspects of the cancer continuum?
Yeah, again, just keep in mind we're brand new at this. We just had we did our work revolving around this. But yeah, I think it's really important, especially for the leadership of the coalition, to have their ears open and make sure that we're hearing what as things may come and go, what the coalition is engaged in, what might be another road to travel down, as we're looking for new priorities, and make sure that we are being as inclusive in that decision-making process as possible, so that we don't miss out on any opportunities for creating that value add.
Great, thank you. We have another question from Jennifer Knight, who asks, and this is a bit of a teaser question too, what's the new website for cancer control coalitions? And would one of you like to talk a little bit about that as well?
The National Cancer Partnership website?
I think so.
Do you think? Okay, yeah. So this is a new website. It's really a revamp of a quote-unquote old website that we had. It's really, we view it as a portal. It has opportunities to link to all of the other National Cancer Control partners in their websites. We have resources such as the one we just discussed today, the 9 Habits Toolkit and Guide. There are other resources and other toolkits on that website. You'll see each of the partners' priorities and a description of each of the partnership's priorities, the 3 that we talked about today, and the different focus areas that they'll be working on. Margaret, anything that you would add to that? You've been involved in that.
No, I think that's great, and I think the important thing about the new site, the cccnationalpartners.org, is the fact that it's a portal and it's being it really does show a great representation of the different tools and materials available from the different coalitions. So it's a pretty robust site in that regard, and continues to grow as well. You know, so I see we're getting to the top of the hour. I know we have a couple of questions, so I know we're going to continue this discussion online at researchtoreality.gov, and we'll be adding the links to some of the materials that Karin, Leslie, Angela, and Brooke mentioned, as well as some of John's work will be up on the website. And looking forward to continuing the discussion there. Your feedback is very important to us, and we encourage you to complete our online evaluation. A link to that survey will be sent to you shortly. And I look forward to seeing everyone. Thanking again our wonderful speakers this morning, for Brooke and Angela, and Karin, Leslie, and John, for sharing your expertise and your robust assessment about how best to engage strategic partners around moving evidence-based programs into practice. Looking forward to seeing everybody again next month for our October cyber seminar. Thank you.
And that concludes today's conference. Thank you for participating. You may now disconnect.